Good evening to all the participants of this webinar, and I wish to thank Iris Group for the organization, and in particular I wish to thank Dr. Alessandro Ribolla for the organization and Andrea Perico for technical support. And I wish to greet also two friends, Alessandro Adragna and Fabio Giuppone, two agents of Iris company that were severely affected in this period by COVID-19, but I am happy to say that they are healed and therefore welcome back. In this period we have a little but a terrible enemy, this coronavirus, and therefore we are used to see images like this, with the people all with the mask, and the people smiles, cries, and speak with their eyes. Unfortunately, in some hospitals this is the situation. We have a lot of patients seriously ill, but I thank all the hospitals all around the world for their incredible effort and the very good results in this period. I think that this pandemic is decreasing all in the world. The situation is improving, but I recommend to all to stay home and above all to stay safe. Our city, for example, this is Milan, in this period are empty, and this man you see in the image is Andrea Bocelli, but we hope to see as soon as possible the city full of people. The same is for Venice. Venice is incredibly empty in this period. This is a Palazzo Ducale in Piazza San Marco in Venice. But normally Venice is full of tourists, full of people, and we hope to see again the city with this number of people. I come from Verona. Verona is a Roman city between Milan and Venice, and this is the Roman amphitheater, the arena. This is the Romeo and Juliet balcony. The topic of this webinar is the influence of implant surface on short and long-term implant success and peri-implantitis. The topic is very current because we have been greatly re-evaluated also the machine surface, that is a surface very used in the past. The implant evolution started about 70 years ago with some implant with unusual shape, but after 10 years, about in the 60s, was introduced in the market a particular kind of implant, a narrow implant, to better exploit the narrow ridge. This implant was called Lincoln blade. But the implant evolution, it's better to say the implant revolution, was completed about at the end of the 70s when Professor Brånemark introduced in the market his famous implant. And it was an implant with a machined, in titanium, machined surface. If you follow the evolution of the surfaces of the implant in this timeline, we can see that up to 2000 about, all the implant had machined surface, but after 2000 were introduced in the market active surfaces, and therefore the implant were completely active, completely rough, partially, and the final evolution of this concept is the presence of a part of implant active and a part of implant machined. This is a so-called hybrid implant, but we talk about this particular implant and promising implant at the end of the lecture. Okay, irrespectively of the design of the implant, we can see external connection, internal connection with polish collar or not. All the implants after 2000 had active surfaces. Other kind of implant with tilted shoulders of particular shapes, but all these implants have active surfaces again. Other implants with particular surfaces, for also particular materials. For example, this implant has a part, an intermediate part in tantalum, but anyway all these implants have active surfaces. Okay, the difference between the two surfaces, machine surface and active surface, is this. If we take a look to the machined implant at low magnification, it seems to be smooth, polished, but at higher magnification we can appreciate that the machined surface is not smooth, but there is a moderate roughness. This image shows the cell have a good adhesion also to the machine surface. The active surface, the rough surface, is clearly a rough surface also at low magnification. Increasing the magnification, you can appreciate the fineness of the active surface. In particular, this surface is the SLA surface, double-edged and sandblasted surface. This is a T-unite surface, and you can appreciate the wonderful image of this surface and the growth of the cells in these craters, in these holes. Also for SLA, for example, rough surface, there is an excellent cell adhesion. The first question is, are there any studies comparing the two surfaces? The answer is that there is a recent paper published 5 years ago by the group of Dr. Esposito and the University of Bologna. The study compared the behavior of full arch rehabilitation performed with machine implant and active surface implant. The result, this is an RCT study, therefore a randomized clinical trial, a very good study. The results are good and similar, and you can see in the image the provisional rehabilitation and the definitive rehabilitation. The authors highlight an important difference. They observed that in the group of the machine implant there were 2 early failures, and this concept is very important. Keep in mind. Okay. The only observation is that this study had only 1 year of follow-up, and therefore is a preliminary study, but these implants are in the market not since a lot of time. Okay, evaluating longer follow-up, we can see this study by Turkelmas. It is incredible to see a follow-up of 30 years for a machined implant in full arch screw rehabilitation. Here you can see a rehabilitation after 32 years of follow-up, of loading. And the results are incredible because the study observes 100% of survival with 2 mm and 0.6 of marginal bone loss. But the important result is that in this machine implant there were no late failures. Therefore, this study, this meta-analysis, evaluated in 1997 the difference between the implants present in the market in that period, and in particular the Bernardello machine implant and the Calcitech IMZ and ITI implant with rough surface. And the difference was evident. In the Bernardello groups, the researchers showed a higher incidence of early failures. On the other hand, evaluating the rough implant, they observed a constant increasing of failure rate over time and a higher prevalence of late failures. Therefore, there is a clear difference between the two surfaces. The machined surface has more early failures. The rough surface have more late failures. It is very important to observe these two differences. Okay, another study similar to the previous was published in 2014 in a wider study, a systematic review with a lot of studies, a lot of implants, 38 implant systems. But the results are very similar because the author observed more early failures in the group of the machine implant also if the difference was not statistically significant. But in the same study, the researchers observed as evaluating only 4 RCT studies with only 3 years of loading, they found an increased risk of 20% of peri-implantitis in the rough implants group. Okay, therefore the question is, which surface is more susceptible to infection, the machine one or the active one? And if you consider a very active, very rough surface, for example, hydroxylapatite surface, this surface is very interesting, is an implant coated by highly crystalline hydroxylapatitis, so-called MP1, a wonderful bone-to-implant contact, a wonderful osseointegration. I used in the first phases of my, I can say, my career as implantologist. I used this implant, and I am very happy to have used. In fact, you see that this implant, for example, after 15 years of loading, is absolutely perfect. No bone loss, no marginal bone loss, and corticalization of the bone, therefore, is perfect. Other cases, 12 years, 14 years, 18 years, 20 years, the bone level is absolutely perfect. For example, also in this case, this tooth was lost and a new implant was inserted, but the old implant was absolutely perfect, and therefore we can say that this implant is absolutely excellent as a behavior, a follow-up. But in some cases, especially in patients with periodontal disease of poor hygiene compliance, I observed some cases with important bone loss, as in this case after 8 years, 9 years. For example, in this case, I performed an implantoplasty in the attempt to improve the situation, but the result was that one or two implants was quickly lost. Other cases, for example, 7 years, 8 years, 9 years, 10 years, show a behavior terrible. You can see terrible peri-implantitis. In this group of patients with poor hygiene compliance, it is frequent to see this behavior of this hydroxylapatite implant. And I say that similar to what happens in the weddings, there is the famous 7th year crisis. Very interesting is also the failure pattern of this kind of implant. For example, this hydroxylapatite implant is a case of my office. After 3 years, green light, perfect. 5 years, perfect. 8 years, green light, perfect. But after 9 years, there is some. I noticed some problem, some bone loss, a peri-implantitis with suppuration, and only after 6 months the implant were completely failed, and I have to remove. Therefore, we can say that this particular kind of implant show an aggressive progression of peri-implantitis. Of course, in this case, I performed a new rehabilitation of the patient, and the situation now is good and stable. Okay, this is my experience, my clinical experience with this kind of implant. But what about the literature regarding this MP1 hydroxylapatite surface? 90% of success rate, completely different from my experience. But the problem is that this study has only 5 years of follow-up. If you observe study with a longer follow-up, for example 10 years of follow-up, we observe a failure rate of 18%, similar to the failure rate I observed in my personal casuistry. Okay, the conclusion is that the rougher the surface, the higher the late failure rate in this kind of active rough implant. Okay, now we try to compare the behavior of machined and rough implant in augmented sites, for example in lifted sinuses. This study, published by Wallace and Fromm, evaluated the behavior of these two implants with machined of or rough surfaces, and they observed as the survival of rough implants in lifted sinuses was greater than in the machine group, but the cumulative survival rate was 91%. The problem was that this study has a short follow-up. A similar study was published 1 year later, yes, in 2004, by an Italian study group, Del Fabbro, Testori, Francetti, Weinstein, and the results are similar. Also in this study, a better survival of a rough implant if compared with a machine implant, and a cumulative survival rate of about 91%. The follow-up in this study is longer. But if we observe the behavior of a only machine implant in left sinus, we can evaluate this study published by Professor Massimo Simio, because this study is very interesting, because the follow-up is at 12 years, and the survival rate is very good. Therefore, we can state that machine implant in lifted sinuses have absolutely a good behavior. Moreover, this kind of implants have, in this case 3, there were observed no perimplantitis. Of course, also a machine implant have perimplantitis, but the incidence is very low. But in this case, the implant had a marginal bone loss very limited for all the years. After 12 years, less than 1 millimeter of marginal bone loss. You can appreciate the stability of the bone level after over time, up to 12 years. Now, another interesting evaluation, the behavior, for example, of the two surfaces in regeneration, in particular in vertical guided bone regeneration, which is a very challenging kind of regeneration. Machine implant in this study by Massimo Simio showed a total survival rate of 97%, 97.3%, and you could say easily, but this follow-up is too short, 1 to 5 years. Okay, I agree with you. But remember, please remember, taking in your mind this survival rate, 97.3%. Professor Simio published another study, also evaluating machine implants in vertical GBR, but with a longer follow-up, up to 21 years, with an average follow-up period of 16 years, and the survival rate was 97%. Therefore, we can immediately understand that the reason is that machine implants have no late failures, no difference between 1 to 5 follow-up period and the 16-year follow-up period. And it is important to remember this concept. Machine implants generally have no late failures. Here you can appreciate the stability of the bone levels. Moreover, in the study, Massimo Simio evaluated also the incidence of perimplantitis, that was about 10%, and we perfectly know that also machine implants have perimplantitis, but we talk at the end of the webinar about the treatment of this kind of implantitis. But very interesting is the minimal peri-implantitis progression. In fact, if you observe this sequence of radiographs, this in the second implant there was a peri-implantitis in 2004, and if you observe the bone level after 9 years, the level, we can say, they are identical, and therefore there is a very limited tendency to the progression of the perimplantitis in this kind of implant, also in vertical guided bone regeneration. But what about rough implant in vertical guided bone regeneration? The implant survival is lower than in the machine group, and you can see that we have 93% 6.6% of success and therefore 6.4% of failure rate, and after 1 to 6 follow-up years of follow-up, therefore a short to medium follow-up. Professor Simeon has in preparation this study with a longer follow-up, 11 years of follow-up, and the failure rate is about 10.5%. But it is very scary, in my opinion, to observe, as this kind of implants have an incidence about 30% of periimplantitis. Periimplantitis. What is periimplantitis? Periimplantitis is a plaque-associated pathologic condition with inflammation of periimplant mucosa, but important, a progressive supporting of bone loss. Progressive. The bone loss has to be progressive. And the incidence of periimplantitis in the two groups. In the machine group, the incidence of periimplantitis, obviously, I repeat, also in machine implant we have periimplantitis, but you can say that the incidence is very low, is very limited. In the rough group, the incidence is absolutely higher, 10%, 11.5%, and therefore we appreciate immediately a difference. And the concept is very simple. The rougher the implant surface, the greater the risk of periimplantitis. But what happens if we have a periimplantitis? Of course, if the periimplantitis involves more than half of the implant, the suggestion is to remove the implant in almost the cases. But if we decide to treat an implant with periimplantitis, the only way to treat, the only therapy is an implantoplasty, a perfect debridement of the area of periimplantitis, and you can evaluate the 1 year success if you have after 1 year a probing lower than 5 mm, absence of bleeding on probing and suppuration on probing, and no further bone loss, because, I repeat, periimplantitis is a progressive a pathology with progression of bone loss. Okay, if we evaluate the cumulative success rate of the periimplantitis treatment for machined and rough implant, we have a success rate of this kind of therapy about 45%. But if we split the two response to treatment in machine implants, we observe that machine implants have a very good response to treatment, 79%. On the other hand, the success rate for rough implant is only 34%. Therefore, the rougher the implant surface, the lower the treatment success rate. Now, we try to summarize the best feature of the machine group, the machine surface, and the rough surface. For example, the follow-up is absolutely good for both groups. The first important difference is that in the machine group we have more early failures, no doubts. Late failures are increased surely in the rough group. Full arch works well in both groups. The bone-to-implant contact is surely greater and better in the rough surface, but the follow-up is good for both the surfaces. Also for the follow-up for guided bone regeneration, and we have seen it is better in the machine group. But very important is the risk of periimplantitis, which is absolutely increased for the rough group, and more important, in my opinion, is the possibility to treat the periimplantitis with better result for machine surface if compared with active surface. And therefore, how to combine the best feature of these two kind of surfaces? This is one good idea, one possibility, the so-called hybrid implant, an implant with the 40% coronal part machined and the other part, the 60% apical part, active. The active part is a moderately active surface, SLA, double-edged and sandblasted. we can see the image of the moderate roughness of the machine part and the greater roughness of SLA surface. Which is the rationale of machined part in the coronal part of this hybrid implant? Of course, the rationale is because machine implants have a good and long follow-up, also in guided bone regeneration, in sinus lift, and important because with machine implant we have limited late failures and limited marginal bone loss. And of course, if we consider that the perimplantitis starts from the coronal part of the implant, the machine surface is important because he has less risk of perimplantitis, a good response to the treatment. The rationale to have active surface in the apical part of the implant is the well-known limited early failures for the active surface, and for example in case of sinus lift, the fact that we have good, very greater bone-to-implant contact in lifted sinuses, and we can easily understand as the part of the implant in the lifted sinus is the apical part, therefore we have a treated part. Okay, after a lot of literature, we can see some blood, some clinical cases. This is a case of hybrid implant. For example, in this case, I used an hybrid implant for a CRESTAL sinus lift. In this case, we have a residual bone height of 3.28 mm, sufficient to stabilize immediately an implant, therefore one-stage approach for CRESTAL sinus lift. And important is to evaluate the width of the sinus. In this case, the sinus is not particularly narrow, but also not particularly wide. Therefore, is a borderline case for CRESTAL sinus lift. This is the baseline check, and this is a control after 4 or 5 years of loading. The blue line represents the sinus floor, and the yellow line represents the transition from the machine part in the coronal portion of the implant and the rough part. And for example, in CRESTAL sinus lift, in my opinion, the hybrid implant is perfect because we have rough surface in the grafted, in the lifted sinus in the graft, and we know that there is a better bone-to-implant contact if you have an active surface, and we have machined surface in the coronal part, and this is very important in the future for the prevention of perimplantitis or of marginal bone loss. Another case, you can see an important radiolucency in this element, in this tooth. There is a very deep probing. In this case, the diagnosis is the fracture of the tooth. The CBCT scan confirms the situation with an important disappearance of the buccal plate, an important bone loss. In this case, the decision was to perform a socket reconstruction using a collagen resorbable membrane and a xenograft. In this case, the membrane was positioned in the part of where the buccal bone was missing. The graft was inserted. The healing was for second intention, therefore this part was maintained exposed. But the healing was very good, and after 5 months, the X-ray image was very comfortable. The maintaining of the volume was excellent. In fact, this maintaining of the volumes allowed me to perform a flapless approach. You can see an hybrid implant inserted with flapless approach. Here you can observe the check at the baseline. All this part is the regenerated part with a good amount of bone or young bone, we can say, bone information in the buccal part of the implant. And here you can see the implant after 1 year of loading. And in this case, the rationale of using this hybrid implant, in my opinion, is the possibility to have active surface in the pristine bone and therefore less risk of early failures, and the machine part in the great part of the augmented bone, and therefore I hope to have less risk to have marginal bone loss of peri-implantitis, because in this part we have a regenerated bone, and we have seen that in guided bone regeneration the behavior of a machine implant is better than the behavior of active implants. Last case. In this case we can see first and second upper right molar with hopeless. The two molars have been extracted, and apparently the situation was good observing the orthopantomography. But it is important to observe always the three-dimensional image, the CBCT, and the surprise was that all the buccal plate was disappeared, and the ridge was absolutely very thin, with only 2 mm of residual bone height below the sinus, and only a little layer of bone in the palatal part of the ridge. In this case, I decided to perform an horizontal guided bone regeneration with a CRESTAL sinus lift. This is the image at the baseline of the sinus lift. You can appreciate the regeneration immediately after the surgical phase. This is the project and this is the realization, and so adding the guided bone regeneration increasing with the sinus lift, the result was comfortable, about 11 mm of ridge potentially, obviously, because after 6 months the situation was good. This is the image of the CBCT and the axial image, and you appreciate a good mineralization of the ridge. This is another image of the cross after 6 months, and therefore the situation was that I had 7.5 mm available millimeter in width of the ridge and about 30 mm in height. Therefore I inserted an hybrid implant of 11.5 mm. And why an hybrid implant in this case? The reason is clear in my opinion, because if we observe the implant, in this case we will have the implant in the coronal part inserted in a regenerated bone, and therefore we have a machine part and therefore less risk of peri-implantitis and marginal bone loss. But the apical part of implant, that is rough, is inserted in a augmented sinus, and therefore in my opinion is absolutely perfect. After 4 years of loading, the situation is absolutely good, as you can see in this cross image. The ghost of the old bone, the initial bone, and now the situation is good. Okay, this implant is a young implant because it is available in the market, I think, no more than 4 years. And but there are some publications, and I had the possibility and the honor to collaborate with this publication published by my friend Sergio Spinato and Paolo Sassatelli, Professor Zaffe of University of Modena. In this case, we evaluated the behavior of hybrid implants in healthy patients and in periodontally compromised patients, of course, in treatment, in maintaining treatment. The rationale of this study was to evaluate the behavior because in periodontally compromised patients we know that we have greater incidence of marginal bone loss and peri-implantitis. Of course, the study is a preliminary study. There is only 1 year of loading, 1 year of follow-up, but the bone loss is absolutely the same in both groups, therefore in healthy patients and in periodontally compromised patients. And therefore, we can say that the machine surface is less susceptible to peri-implantitis, because also in periodontally compromised patients we have no marginal bone loss. Of course, we are waiting for longer follow-ups, but the preliminary results are absolutely encouraging. Another study published by the same group, Sergio Spinato and Paolo Sassotelli and Davide Zaffe, published 3 years ago, evaluating, in this case, hybrid implant and a fully treated implant in a periodontally healthy patient, because the question was if the hybrid, the machined part of the hybrid implant could have the same stability of the bone. And you can see the hybrid implant, the difference between the two implants, hybrid implant and an implant with only 1 millimeter and a half of machined collar. In this case, evaluating the periodontally healthy patient, we observed no difference in marginal bone loss and in survival in both groups. Therefore, we can state that also the machined surface have no particular marginal bone loss, also if the coronal part of the implant is not treated. Another important outcome of this study was the result that the higher the prosthetic abutment height, the lesser the marginal bone loss. This is an important concept. We can say that when we have an height of the abutment more than 2.5 millimeter, the implant tends to have a minimal marginal bone loss. The marginal bone loss is highly increased in presence of short abutment height. In conclusion, when I could suggest you to use hybrid implants, surely in periodontally compromised patients, for the reason I have explained, because the coronal machine part is more susceptible to marginal bone loss and peri-implantitis, especially in periodontally compromised patients. For the same reason, in patients with poor oral hygiene compliance, because in presence of poor hygiene compliance, we have more risk to have marginal bone loss, and machined surface is less susceptible of marginal bone loss. Surely in cases of previous implant failures, in patients, in heavy smokers, and in diabetics. And now I conclude this webinar not with a sentence, but with a question for you. But are these not the majority of patients for our implantology? Thank you for your attention, and if you have some question, please await your question. Thanks so much again for your participation.